Welcome everyone to today's webinar, What About the Other 50% of Spending? I'm Gabrielle Mason with Becker's Hospital Review. On behalf of Becker's Healthcare, thank you so much for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link that you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help you. With that, I'm so pleased to welcome today's speaker, Robert Bessler, MD, CEO and founder of Sound Physicians. Dr. Bessler, thank you so much for being here today. I'll now turn the floor over to you.
Great, thank you, and terrific to be with you all today. I wanted to warmly welcome all of my partners at Sound, our physician owners, nurse practitioners, nurses on the line, our hospital partners that are joining us, other hospitals, some of our competitors, and even family member on today. So really glad to be with you all. Today, we're going to cover four main areas, a little bit about our view of where value-based care is falling short, some of the strategies that we've implemented and are proud to talk about, a little bit about our delivering on reproducible outcomes, and then how we're going to really look into the future here of what's to come. Essentially, the whole idea here is, as a physician practice at scale around the country, we work inside the walls of hospitals across the acute episode of care, and you've seen this type of slide from many different angles, but from the view of some of the challenges on the economics, you have Medicare and commercial payers trying to squeeze physicians even lower. You have hospitals that have been squeezed through the ACA and have trouble paying or subsidizing a practice for taking care of the uninsured and underinsured. And you have a supply-demand imbalance, which has created massive wage inflation over the years for clinicians. Obviously, we as a country have plenty of opportunity on clinical outcomes, and all of us that have been patients believe that there could be a better model out there to serve our needs as individuals. As far as value-based care goes, what's interesting to us is that half of every dollar spent in the U.S. healthcare system happens from the time a patient is admitted to the hospital through the 86 or so days after discharge. That's about $1.9 trillion of spending today. It's our estimate and third-party expert estimates that about only $200 billion of that $1.9 billion of spend today is in some sort of episode or value-based care model, with either government or private/commercial insurers. And we have a very small piece of that. We at Sound take about $1.6 billion of risk today across the country, which is small on a relative basis, maybe 3% of the total. We probably care for 6 to 7% of all Medicare admissions in the United States. And so, we're obviously not on doing that amount in the risk area. But the demand continues to increase, and that is really the purpose of today's discussion. And the demand is coming from three areas. Number one, CMS has announced a move towards mandatory bundles in 2023. A lot of hospitals really haven't woken up to this reality that the average hospital in the United States in 2024, after this program's implemented, has a new 8-figure risk that they don't have today if they're not participating in the program. And private payers, while many private payers would love to move as many patients as possible that they're taking risk on to full capitation and pass that risk on to either a health system or a provider group, we know that the vast majority of patients still, even though there's continuing penetration in this area, most of the payers have tons of patients that are not covered by a capitated model. And so the demand for episode-based care and improved utilization it continues. And then health systems are quickly moving into this arena. Most health systems are not making a profit on Medicare medical patients, never mind Medicaid. And so there's a huge opportunity, whether it's through the ACOs or other models, for competing for both private patients in risk payments. Nothing you don't all already know. The experts do claim that 60 to 70% of all healthcare payments will be in some sort of value-based care arrangement by 2025, which used to feel like a eternity and is around the corner. So the 50% that's been getting the most attention, has been in the primary care space, where all these different groups, whether they've gone public or they're just on rocket fuel of taking more covered lives. But even the best of these groups in the country are still spending over 50% of their spend on the acute episode, or the part that they really have almost no control. Most of these at-risk groups don't have a hospital-based solution, and a bunch of these groups have experienced some pretty meaningful headwinds as of late, partially due to their inability to control costs on the inpatient setting and post-acute setting after that. And what we have found is lots of hospitals have a strong interest in being more attractive to these sorts of providers as well. And we have become a big lever, and all of these types of groups have become a client of ours to serve their patients and drive market share to our existing hospital partners. Finally, I think pictures say 1,000 words. Every month, 120,000 new people enter Medicare, and any one of the top football stadiums. It's kind of good imagery for you if every month was filled up with new seniors or new people turning 65. And so we don't see this ending anytime soon. We feel like people are living longer, and more people aging into Medicare, that this problem is just going to continue, and that real solutions to manage that other 50% of spend need to happen. So in the best scenario, MA, there's pretty good data that says there's lower admissions. I think the data is pretty compelling. I'm an emergency physician by background, and if I know a patient has a primary care provider, I can talk to them on the phone and I can get them in the next day to be checked again. I have a lot more confidence sending them out of the emergency department versus most patients. In a fee-for-service environment, there's, the ability to get them in within 7 days is not that great. And so what it says is over 77% of the Medicare admissions remain, huge opportunity to reduce readmissions, and a significant portion of the lives are already, being admitted. So really, there's a ton of work to be done on this 50%. I like to use this graph to kind of explain where the money is being spent. So in the prevailing models of primary care, it's all about keeping people healthy, and we believe strongly in that. But the reality is our average age patient is 76. Our average patient has 8 different medical problems on multiple medications. And the inpatient stay of this 50% of healthcare spend only is about 34%, 35% of the total spend across that 90-day period. As you can see, the vast majority of the spend comes from readmissions, skilled nursing home usage, and then a whole smattering of other areas, including pretty significant Part B spend for professional services. And, I think we know this is growing. We have MA plans continuing to grow at a rapid rate. We have some markets at Sound where over 50% of the patients with Medicare are in an MA plan, and we have other markets lagging in the high 20s. So it's all over the place. CMMI is very serious about the mandatory bundle program, and we know that from demand from at-risk medical groups that they really need a solution as well. So a little bit, just real brief, who we are for those that don't know. we believe we're a leader in a big national group focused on value-based care, delivering reproducible outcomes across that acute episode of care in emergency medicine, hospital medicine, critical care, and anesthesia. We cut all of our teeth in hospital medicine, and today we have over 350 different hospital relationships. We're in over 200 different value-based care contracts. We have both commercial and Medicare spend at risk of over $2 billion, about 100,000 annual episodes of risk. And what's interesting is obviously we send about 15% or so of our patients to nursing homes, and so we have a lot of nursing home volume. And back in 2015, we began investing heavily in moving from what I would describe as pay-for-performance to value-based care. And then we're partnered with over 60 different ACOs and then various at-risk physician groups and health plans around the acute episode of care as well. And I think it's really important to note that we only enter an agreement with a risk-bearing entity that's aligned with our hospital partner. So if a hospital partner is at capacity, isn't making money on Medicare patients, we have a few hospitals that want to share in a model to prevent unnecessary admissions, but of the vast majority, there's only a handful of those. Every other opportunity is around how do we lower our post-acute utilization, unnecessary post-acute utilization, how do we prevent readmission and get people to the right level of care after they're admitted. So there's 5 really operational principles that we're focused on, and I'm going to share a little bit about these with you today. If you put your phone on the QR code, you can get immediate to our article that John Berkmeyer, our Chief Clinical Officer, and I wrote for the New England Journal, focused on going into great detail on these areas. But really, it's pretty straightforward, and I'll walk you through a little bit of the sausage making here. But essentially, aligned incentives around provider accountability. As a physician-run and led group, we believe strongly in putting that meaningful data in the hands of our clinicians. Purpose-built workflows, you need to have a technology solution. We built one over the years. We started building our solution in 2004. Clinical focus, we'll talk a lot about this, and then real-time analytics is super important. And then we've come up with some pretty innovative ways to fill what I would describe as gaps in the system today. So number one, one of the things that we missed the boat on out of the gate was we talked about lowering cost. And I would urge you to not spend a bunch of time with, we have thousands of clinicians, and when we started gaining real momentum, when we shifted the conversation to all these programs that we've created are about better outcomes for patients. And when you get better outcomes for patients, you actually get better results, and one of them is lower cost. And a perfect example is we used to send patients to nursing homes based on who had a bed available, who had a nice lobby. And I would argue that no different than the FDA coming out with a black box warning on a drug, I stop prescribing it tomorrow or today, I guess. We no longer just send patients to who has a bed or who has a nice lobby, because the variation in outcomes for patients is dramatic. And frankly, some nursing homes hurt people and others do a fantastic job. And the data is very compelling. So that's number one, is really strong on education and performance incentives around that. And the other big learning is, we used to have everybody do all this work. And what we learned is, especially at programs, for example, where we have 20 or 30 physicians, it's really hard to get 20 to 30 people of any, level, never mind independent thinking, high quality clinicians, to all operate in the exact same way. So what we did is we narrowed the focus. We created what we call high-risk teams, where we're able to cohort our risk patients that we're partnered with the hospital on into small teams to manage these patients. It's more intensive, value-oriented, and what you can see on the right is we measured the results at sites where we had high-risk teams versus non-high-risk teams, and this is at scale, so the N is high, the p-value is high. Or low, I guess, and the results are pretty dramatic. That We have a metric called the weighted post-acute utilization metric, weighted PACU, and it's basically an indicator of the intensity of post-acute services after discharge, and it lowered dramatically with the high-risk teams. We had a very big increase in the number of advanced care planning discussions, and I'll talk about that, and then pretty dramatic avoidable readmission reduction as well. The second thing is really about workflow. So no one will ever hear me say, you know, we have better clinicians. I think everyone's board certified, everyone went to great medical schools, everybody got trained, everybody passed the same set of boards. I could argue maybe some people's, that mothers taught them better than others in certain groups, and we'll take that one, and we do plenty of training. But what we are very confident in is that if you have better process, you can get better outcomes. But better process includes both leadership, training, technology, and as an example of that, we know that patients come in their most dire state, and there's a massive underutilization of what we describe as advanced care planning. And what we have done in our software solution called Sound Connect is we created a pop-up question for our clinicians based on an algorithm on the patient's age and diagnosis, et cetera, of asking the surprise question. For those that aren't aware, the surprise question is an evidence-based question of if you ask a physician or a nurse practitioner, would you be surprised if this patient wasn't alive in a year? And if the clinician says they would not be surprised, it should trigger an advanced care planning discussion around goals of care. And we've had an 8x increase in the use of advanced care planning compared to the Medicare database through great documentation and really, patient wishes. And this has really there's a massive correlation between patient experience scores and the use of advanced care planning. So we put this provider dashboard in front of every physician. You can see in small print here, things like the high quality network utilization. We know which nursing homes provide better outcomes as they go in our network. And then you can see individual physician versus national and local averages on the advanced care planning. Another area of interest has been, how do you know which patients you're taking risk on? And it's remarkable to me how many ACOs in the country, when the patient gets admitted, the providers in the hospital have no idea that these are their risk patients. So we built a technology platform within Sound Connect, basically Sound Exchange, that basically allows us to ping a database. If we're taking risk for a hospital's ACO and we get the provider database or the patient database, we ping it in real time, and our technology allows us to flag those patients. In addition, same thing for an at-risk medical group or a bundle patient. The same thing goes for, we have some predictive analytics embedded in our technology. It's not that complicated, but readmission risk issues and obviously the advanced care planning workflows. So you can see that all here. And it's surprising how many hospitals, just this alone has a huge opportunity of just, obviously you can't manage what you're not measuring, and you can't put in interventions on every patient. It's just not feasible financially. So the financial and analytical oversight is super important. This is a provider dashboard. We look not only at the HCAHPS by discharging physician, but also readmissions, advanced care planning, the weighted post-acute utilization metrics, what percentage of our patients are going to our high-quality network, and then some obvious blocking and tackling stuff around length of stay, discharges before 10 a.m. by provider, and the case mix of the physician, and then by discharge. And then a very key metric that we've come up with is the follow-up to discharge ratio for those in the weeds on the physician side of things. The billing, every day a doctor has a choice to make one of 3 follow-up visit codes once the patient's in the hospital, or a discharge code. And if you took the sum of the follow-up visits by the sum of the discharge codes, you really get at individual physician decision-making behavior, and certain physicians pushing water under the bridge and waiting till tomorrow, and other physicians that really move patients through the system. And so just another way to track and promote accountability. The 5th area is really, how do we collaborate outside the walls of the hospital? Obviously, with community physicians, it's all about great communication. And then we select high-quality SNFs in partnership with our health system, and we look at the data, and so that it's not just about who brought donuts or who has a nice lobby, but who's actually delivering better care. Same on the home health side, based on, turnaround times and seeing patients within 24 hours. One of the things we require to be in our high-quality network for home health is our 2-week protocol. So most of you probably know that Medicare pays for 16 visits, I believe, in the first 30 days for home health. However, they don't dictate when those patients are seen, and what we've found is a lot of those patients are seen based on the staffing ability or convenience to the home health agency. And we say, hey, to be in our home health high-quality network, you need to stack and front-load those in the first 2 weeks, and it just so happens that patients get better outcomes in that scenario. And then finally, where we play in telemedicine, we do have a hospital-based telemedicine in critical care for either surge capacity, extra coverage at night, et cetera, and rural hospitals that don't need in-house. But the biggest area of growth, and today we're in hundreds and hundreds of nursing homes. I think it's over 400 today, with a recent integration with the largest EMR for nursing homes, point-click care, will soon be in thousands of nursing homes. We found that there's a huge opportunity to provide night coverage in the nursing home to what I call get rid of lazy medicine and prevent readmissions after hours. And so as an ED physician, if I get a patient that's, demented at 3 in the morning, 90 years old, with a stack of paperwork and has some diagnosis, it's pretty easy to find a reason to admit them. If my SNF telemedicine internist, hospitalist sees the patient in the, they can prevent that patient from coming in. And if they do come in, they can call me. And, if the patient fell out of bed and all they needed was a CAT scan and send them back, if that's normal, we've found a dramatic improvement in outcomes. 50% of those patients go back to the nursing home. We also can extend our telemedicine in home health. I'll talk about that here, and then SNF at home as well. So in our SNF telemedicine practice, across 43 sites, we were able to lower our 30-day hospital readmissions by 23% by getting what I call getting rid of lazy medicine. And it's even more dramatic when we support nurse practitioners that are covering MA lives. So pretty interesting outcomes that's led to really fast expansion. And then on the home health side, what's interesting is about 10% of all home health referrals never get filled for the home health agency because of a lack of certification. And so our hospitalists are providing these as well through telemedicine for our hospital partners that own their own home health. And obviously, nurses that go into the home occasionally need a physician in real time. And we have about, I believe it's about 80 full-time telemedicine hospitalists that are doing this work today. And then just a little bit around our bundle program and episodes. We're very proud of this data, partnering with our hospitals around outcomes. And what you can see here is, and this is from the prior, the data that's complete, we have a 30-day readmission rate that's about 26% below average. And then we lowered LTAC utilization from baseline by 60% for unnecessary utilization. And then SNF utilization is down about 15%. It translates into about $1,000 an episode, and it's what's most important, especially in the new program that's moved to retrospective trend, is we've lowered trend by 4 times faster than the average, the yellow line versus the gray dots, yellow dots versus the gray dots. And then, bringing this to various payers, whether it's Humana, United, et cetera, this is just one example across 120 sites. We were able to improve where patients go, get more people home instead of to SNFs. We dramatically improved where they go to a preferred SNF, some serious improvement in preferred home health agencies that have better outcomes. And then the observed to expected readmissions improved slightly, and that translated with a better managed population than fee-for-service Medicare, to about $464 of savings per episode. And then finally, another interesting area that is underappreciated is in whether you're an MA plan or an ACO, capturing all of the diagnosis is super important to accurately represent the acuity of your patients and ultimately the revenue you'll receive because of the higher utilization of sicker patients. And what we didn't recognize early on is that out of interest, about 30% of MA patients don't have a PCP visit in the last year when they show up and get admitted to the hospital. So there's been no opportunity to fill in the gaps in care and the documentation. So we had done a pilot with an at-risk medical group out of Texas, and we, over in the yellow bar on the bottom are patients that, our doctor completed an attestation, but there was no additional documentation required. And the green bar is they did the attestation, but there was improved documentation. So we created a link to the risk-bearing entity, hospital ACO or the MA plan, et cetera. We showed a massive ROI. The RAF improvement was about 0.54. We just get paid a flat fee to do it because of compliance reasons, of course, but it's just it's a good thing. It improves documentation. The doctor gets paid to do the work, and the risk-bearing entity has an opportunity to capture more of the risk dollars. And as we look into the future, there's been lots of out there around where things are going in Medicare. We're obviously close to this with the folks in DC. It's a great team that are just trying to do the right thing and help our nation's seniors. And I think, there's three potential paths, and you can read the whole white paper by putting your phone over the QR code here. But essentially, there's three really approaches. One is exclude clinicians from the mandatory bundles, which is similar to the CJR model. There's the model that exists today where physicians or hospitals can participate independently and figure it out amongst themselves if they're going to share. And then you have a modified model, which we obviously believe strongly in, around physician and hospitals collaboration and to the benefit of the patient. So that's really kind of what we're focused on, and we think there's a really straightforward model that supports this and also works very collaboratively with an ACO model. And I think don't have a crystal ball, don't know how things are going to play out. I think it's pretty fair to say that MA will continue to grow, seniors will continue to live longer, and there'll be more of them. Hospitals and our health system in general will be under a crunch, and so I think now's the time to really address that 50% of spend, and I hope you would agree. We left plenty of time for Q&A, so really thankful that you all joined today, and look forward to answering your questions.
Well, thank you so much, Dr. Bessler, for that really great presentation. Like you said, we'll now begin today's question and answer session. And to our audience members, you can submit any questions you have by typing them into the Q&A chat box on your webinar console. So let's get started here. The first question, an audience member wants to know, early in the presentation, Dr. Bessler, you spoke about the work being done to reduce unnecessary admissions. Can you talk a bit about reducing admissions in the context of a fee-for-service reimbursement model?
Yeah, thanks for the question. We absolutely partner with our hospitals. We follow Millman or whatever the guidelines locally are, but usually it's a Millman guideline for appropriateness of admissions. And we're definitely in the business of admitting the appropriate people. Most of our hospitals are still in a majority fee-for-service environment. I would say most of our hospitals are not generating a lot of earnings or contribution margin from Medicare medical patients. And so there's general alignment that let's just take great care of people and get them through the system as efficiently as possible. What's more interesting is this whole readmission issue, and like we see all over the map, most, I would say, hospitals don't see the penalty high enough yet to, incentivize preventing readmissions, other than because it's the right thing to do. I would say that medical readmissions, especially from SNFs, are a money-losing proposition. Every CFO I've ever talked to kind of shakes their head up and down and agrees with that. So that's really the focus. And so, we're the only, like I mentioned, we only have a few hospitals where we have a three-way model between us and the payer and the hospital, where there's, work being done at the ED on appropriately finding other solutions, whether it's the hospital at home model or, going or just lowering the number of patients that get admitted because they got a line out the door, they got patients lining the hallway, they got more surgeries they want to do. And so it's a complete alignment. We would never kind of do that without the hospital's blessing. Good question. What's next, Taylor?
Well, a great answer by you, Dr. Bessler, so thank you. Another question is, how do you motivate behavior change in someone who doesn't want to change and is stuck in their ways?
Good question. I think it reminds me of back when I went and met with the folks at Starbucks about, how they get so many people to be happy at the barista counter. And they said to me, you didn't come up here just to ask that, did you? I said, no, but it's really remarkable. And they said, well, we don't hire grumpy people. And they actually measure how quick you smile when they interview you. But I think part of it's how you hire. You can't change. It's similar to like, if you hire a physician in a community hospital and they left an academic center because they no longer wanted to teach, and then all of a sudden there's teaching at this community hospital, you're not going to keep everybody because they didn't want to teach. They wanted. So I think, making sure part of the benefit of our high-risk teams is we can incentivize, we can, appropriately compensate people for digging deeper, doing more work that's generally undercompensated on a work RVU basis or whatever. And so, you got to find the right people to do the work. The easy part is the fact that it's crystal clear that we're getting paid to do the right thing for people, right? More people want to be in their home. They don't want to be in a nursing home if they don't have to be. More people want better care quicker in home health. More people want to know their loved ones being watched at night by telemedicine in a nursing home. And so these are the kind of things that make people our clinicians real believers that we're doing the right thing for people.
That's so interesting about, the Starbucks hiring and the relevance there. On a slightly related note, one audience member would like you to discuss a little further about the incentives you institute for physicians and how that relates to behavior change.
Yeah, I think what we've learned over the years is, if you want to incent physicians, so there's incenting to do the right thing can be a monetary thing. It can also be, the peer-to-peer, like how do you do the right thing for people, and when we show better outcomes and lower readmissions by following various workflows, people jump on board regardless of the money. We all went into medicine, to take good care of people. We all want to do the right thing for patients. And so I would, the easy button is to just say, oh, well, how much comp did you put at risk for this? Well, I think it's a much more complicated question around how do you build culture? How do you get people to see where you're going and do the right thing? And you get a very compelling group of people. We started this focused on how do we build a practice that people can be really proud to be part of. And this is part of that, feeling proud to be part of. Financial incentives do work. We do put dollars at risk for things that are in our clinicians' control that we can measure, right? So you don't want to have you don't want to have cost outcomes that you don't really have control over. you want to have things like, what percentage of your patients went home? How did you, when the patient needed the surprise question was triggered, did you have the advanced care planning discussion? These are the sort of things you want to incentivize versus, outcome measures that they don't really have control over. And I would describe it more as the process markers for the endpoint goal is kind of how we incentivize on the financial side. What's next?
And I'm going to pivot slightly, Dr. Bessler. Which of the three models of bundled payments do you believe is likely to succeed, and why?
I think a collaborative model makes the most sense. I think, the government can't push, or they're reluctant to push risk onto like physicians in small group practices because, they worry they don't have the infrastructure, they need to give them autonomy and control still. And you have hospitals, health systems that have large ACOs have invested heavily in that, but they don't really, it feels like every ACO we've interacted with has a post-acute utilization strategy, and very few have an execution arm. An episode model or the bundle model has a very clear way to interface into the ACO model as a way to help serve those patients to get the better outcome. And so we kind of see that collaboration as a little bit of Captain of Obvious, but kind of the way forward. And, if you always put the patient in the center there, what would you want for your family member? That's probably a good model where you have aligned incentives.
Great. Thank you, Dr. Bessler. Another audience member would like to know, or would like you to describe the ideal model for collaboration between PCPs and hospitalists.
I think the ideal model is that people get to know each other. I think one of the big flaws in a lot of practices out there is you have the community physicians that no longer come into the building, and you have hospitalists that don't have relationships with the community physicians. So one of the things we really focus on is how do we build those connections. The best marketing any one of our docs can do, frankly, is pick up the phone at the end of a stay and at the beginning, frankly, and explain what we're going to do for the patient, and then after the stay, explain what we did for the patient. And it's, when we do a good job and communicate well, it's going to drive a connection between that community physician and that hospital. And so the onus is on us. We deliver data behind the scenes to every PCP practice that we partner with over 76,000 community physicians. So we have a big data feed that goes out to the community physicians on their patients, more of a push than the PCP having to pull something. Our docs get stuck in phone trees all the time, and so this is part of making sure that we have, when we do go to a new place, we get a list of the community physicians, we sign them up, we get a back office phone number so that the doc, our hospitalist or nurse practitioner is not stuck on the phone tree. But then we push data to them as well, and I think that's the best model is great communication.
Another audience member said you mentioned Part B in an area you focus on managing. Can you provide some insight as to your strategies in this space?
Yeah, that's an interesting one. The payers long ago knew that the fastest way to increase Part B spend is order a bunch of consults. We definitely need to consult appropriately because we're not experts in every specialty by any means. But if you put data in front of docs, and the most classic one is a new grad. A new grad, 23 years ago, I'm at the Cleveland Clinic, and specialists run the big house there. And, patients come in, they get a neuro consult, a cardiology consult, and a GI consult, because that's the way you learned it. And so the most important thing we do is put meaningful data in the hands of our docs by physician to understand their own practice pattern. And it's not that we ever want to prevent someone from asking for help, but certain things need to happen in the acute setting and certain things don't need to happen. And the hospital knows that as well. They much rather have that stuff done as a follow-up when they can get an outpatient reimbursement versus it be part of the DRG, because every time you consult a specialist, they also order tests. And so, we need to appropriately consult, and really the most important thing we do is just manage information and put meaningful data in the hands of the docs. No different than imaging utilization. So you'll see in a practice that doesn't have good data and analytics, you'll see ultrasound and CAT scan usage all over the place by physician. And by putting that data in the hands of our docs and our physician leaders, we can then have appropriate conversations, have a journal club on what's the standard workup for pulmonary embolism, et cetera, and not have a lot of variation. Good question.
Thanks for going into detail on that, Dr. Bessler. Another audience viewer would like to know, for individual physician performance dashboards, what's been the reception by physicians? They're just wondering how physicians respond to being compared to others publicly.
Yeah, it's a good question. So we have, this is never easy, of course, but as a physician run and led group, we have a advantage, right? Because if I say something, I've been in their shoes, or my team. We have a physician leadership team that, vets our dashboards and our data. We build trust and rapport with the clinicians about how we're capturing that information, which oftentimes becomes a massive distraction when it's done poorly. And so once we have people understand how it's being tracked, and a lot of it, the docs entering it themselves through like drop-down menus in our technology solution, Sound Connect. So it's pretty straightforward that, this is your data that you produced. And so that's kind of how we do it. And then I think we're all competitive by nature, and we believe very strongly in unblinded data. And, all ships rise in that scenario.
Another audience member would like to know if, do you see advanced primary care models or hospital at home models changing the way payers think about bundled payments?
That's a great question. So I think a lot about this, and we partner with some great hospitals and hospital at home models. There's been not great acceptance for the hospital at home yet, mostly because, the patient thought they were sick enough to come into the hospital, and then you're going to say, you're sick, but we're going to send you home. And the ER doc has a lot of weight on their shoulders, feeling like, wow, I thought this patient was sick, and now I'm going to send him home. It takes a lot of work to get him home, et cetera. Where we think the future is, and I don't really think the urgent care model in the home is going to somehow miraculously find all the patients that could basically stay in the home. That's a model that has some traction. But I do think there's a model where we partner with our hospital and say, take the monkey off the back of the ER doc. So the patient's going to get admitted to our hospitalist. Our hospitalist has multiple choices of where the patient's going to go. They could go to the ICU, they could go to telemetry, they could go to the floor, or they could go home, right? And they're going to go home through a protocol and various diagnoses. And then we're going to be caring for that patient through the hospital's EMR with our telemedicine solution. And this is all in the works that we're doing now and working on. And that is a very viable model as long as you can get all the services into the home. And, we're working with various groups that do this. And I think when the hospital could essentially, you could see a day where the hospital gets a DRG type payment, which they have in the waiver model, but could get from payer as well. And a group like us or somebody else who has the, actuarial horsepower and analytic data and partnerships in the community with the, 18 plus different agencies you need to get into the home, you could then cap the dollars where you build in a contribution dollar amount for the health system for patients that they probably weren't making money on before anyways, creates capacity for the health system without building a new $2 million bed, and creates, virtual capacity in the community essentially. And frankly, a subset of patients probably want that care in the home as long as it can be proven to be safe. So that's kind of where we're going, what we think is happening. It's, hit and miss so far as demand from patients, acceptance from clinicians. But we think the key step is going to be the patient gets admitted from the ER, and the hospitalist is then in charge of placement decision across the, ICU, telemetry, floor, or home as different environments. Good question.
Well, thank you, Dr. Bessler. You're providing so much great insight. We do have a few more questions coming in. One audience member would like to know how you're managing the rising specialty drug spend as part of your value-based model.
That's a good question, and I don't have a great answer for you. One of the ways is don't take risk on patients you can't have control over the spend. So, we don't do anything in oncology as an example. And so if our clinicians don't have control over that, that's a, an obvious one. But I think like anything, if you're a hospital ACO or, and I know every at-risk physician group on the call looks at this data every different way, and they'll cut. And, it's crystal clear that they need to focus on a subset of their population. And it just so happens that 50% of their spend is on the patients that get admitted, and that's our area. There might be another area, which is the high utilizers from a pharmacy spend. Generally, the medical admissions are not, that hasn't been our experience. And obviously, from the payer's perspective, they've capped the cost to them. So whether you're, the Medicare is paying a DRG, so that's on the hospital's risk. Same thing with the physician group or the ACO that's paying the hospital flat amount for the admission.
And I will do, a final call right now. If anyone else has any more questions, please submit them in that Q&A box down below. Dr. Bessler would love to answer them. We do have one more question in the meantime. Dr. Bessler, how does sound get reimbursed?
Yeah, we bill professional services for a few million patients, probably 10 million or so patient visits a year. So we get pro fee reimbursement. We get management fees from hospitals to run the hospital's programs. And obviously we get, I think about our value-based care payments as just professional fees. So instead of being an out-of-network provider like some of our competitors are charging patients or employers, high rates, we can stay competitive on physician comp by getting paid through value-based care. So that's kind of how we think about it.
Great. Well, thank you so much, Dr. Bessler. And for anyone who has any other questions, Dr. Bessler and Sound Physicians can always follow up later as well. Dr. Bessler, do you have any closing thoughts you'd like to share with us today?
Well, for all of our clinicians on the call, thanks for joining in. Hope you didn't learn anything new. And for our hospital partners, thanks for your interest, and for all the others on the call, appreciate it. Feel free to reach out. My email's here. If you have any questions, happy to jump on a phone and answer them or respond by email. Thank you so much. Have a great day.
Well, thank you again, Dr. Bessler, for your excellent presentation, and thank you as well to Sound Physicians for sponsoring today's webinar. To learn more about this content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you so much for joining us today, and we hope you have a wonderful afternoon.